Welcome to the 8 Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Welcome back to the 8 Minute Rule. I've got with me Lucas, Mark, and Drew. Good to have you guys back for this episode. We're going to do part 2 of exercise progression. If you didn't see part 1, go back and check it out. Our goal is to just really take these guys through some of their interventions that they enjoy working with, kind of a little more vague, but just being able to see a good picture of early intervention, mid intervention, and a little bit later. Before we get to that, since we're talking exercise, quick little icebreaker from the guys. What is your preferred time to work out? Lucas, we'll start with you.
Middle of the day.
Middle of the day. Get that sweat on and get a shower, go back to work.
Peak energy is the
Sweating.
middle of the day.
There you go. How about you, Mark?
I'm kind of the same, like just after lunch time frame. That's where peak performance for me is happening.
Man, how do you guys stop sweating during the day? Like, I don't.
Oh, I don't do
100%
it.
humidity
That's
up there.
weekend. My preferred time is weekend. If
Okay.
during the week it's not happening
Just
in the
what
middle
you
of the
During
day.
the week, the only choice is after work.
Yeah.
Oof.
Mm.
Drew,
I'm
I
different.
know your answer, but go ahead.
My staff calls me a 5 a.m. girly because I'm up at 5 working out before work and before the kids wake up. So
Hey,
I'm a morning workout. I can hardly do it in the evening.
that's right. It took me a full year to make that transition, but I'm never going back because that time in the morning is precious, and it's hard to find at any other time. So
I've tried it. I've tried it for 12 months.
looks like you got to try
I did
13 then next time. So
I did years of it and did not like it at all.
fair enough. Fair enough. You may find yourself having to change that up, then, Mark, here pretty soon. We'll see. All right. So I appreciate it, guys. We'll go ahead and kind of jump into looking specifically at Achilles tendinopathy, plantar fasciopathy. We can kind of blend those in to some degree in terms of the treatment from an exercise progression here. So, Drew, why don't you just go ahead and give us a rundown? Early intervention, kind of mid stage, and then what does the late stage look like after that?
Uh, Anyone specific that you want to start with?
For the Achilles tendinopathy or plantar fasciopathy.
Achilles. All right, we'll go Achilles first. So again, I break it down into kind of the symptom modulation, uh, movement, uh, movement control, and then functional optimization. So in the early stages, depending on the acuity, if I'm really trying to decrease the overall pain, there's education around activity modification, and then the analgesic effect from isometrics. That's probably where I'm going to often start. And I think here, this is also a place where the area of pain is important. If it's a insertional Achilles tendinopathy, limiting the dorsiflexion so you're not aggravating it with a compression. If it's mid portion, that's not as important, but anything to help decrease the symptoms early on is going to be the main thing from activity modification to. I haven't had to use this much, but at times, like shoes that have like either a higher heel toe drop or some sort of heel raising versus like a zero drop shoe, if it's that insertional type, can be helpful. But that's that early stage. But then as soon as I can, try to move on to, again, with the general principles, the long, slow exercises, concentric and eccentric. So moving that as quickly as I can. That's early phase.
Yeah, so I like the early phase, and as you talked about the distal versus the mid portion, distal really needing to protect within that range of motion, or else you're going to have a hard time getting to that middle stage out of there as well too, just because it's going to be kicked up. So, but just kind of run me through, Drew. So obviously that's your early stage. What does your mid and in range stage look like in terms of that same setup, that same patient?
With that patient, it's middle is like the movement control. So, what are some of the potential and factors that you're going to see with that? Anywhere from foot intrinsic strengthening to up and down the chain, to where there may be some limitations, um, and then progressive loading. through that course if you get it calmed down, and then building them back up. Um, Ultimate goal usually with these is to get back to where they're able to load that tendon pretty easily, and then getting into more dynamic movement, so like plyometrics, but that's further end stage. So depending on what that patient wants to get back to, if it's more of the athlete, that's where we're going. But there's a lot of times where I'll see the person who's just trying to get into exercise, and they're starting to get they're early on in that phase, and so the education piece of how to progress them is probably the one of the biggest things as you go further on. Promoting activity, exercise, and allowing them to be able to do it with some modification so that it doesn't continue to get aggravated is probably the key for that lower activity patient, the non-athlete who's trying to start to get the healthy lifestyle, so that they don't have the like, I started to try and do some walking, I started to get active, I started having this aggravation, and then it hurt, so I just kind of stopped. Like, you don't want to have that. So continuing that progression from like, hey, now they're out of pain, but how do they get back to where they want to, what they started off doing anyway? That education piece is huge. So it's going to vary based on the patient, but ultimately I want to get them back to that activity, build up exercise, and then potentially adding more loading, quick loading, if it's more of an athlete, to get into the plyometric phase.
Yeah, I like that. I think all your principles apply in a lot of situations, which I think is really helpful in terms of the symptom modulation, getting the movement control down, kind of progressing dynamic. I was thinking through as you were talking about this. I have a patient right now that is kind of a distal and had been through 6 months of different things before coming to see me, and so he was very much in the chronic phase. And within 6 weeks, we finally got him turned around from the symptom modulation to starting to take a little bit of load, but he still had, especially because it was distal, he's had some kind of back and forth weeks where he tries to do too much, he gets kicked up. And so education's been such a big deal with like, hey, this takes time. Like this can really take some time. You're trying to remodel structures, you're trying to get them back to where they tolerate the load in there. So I love how education is still a key piece as you're working through there. So, um, Mark, as we're looking kind of in this same setup, Drew obviously had some overarching ideas about what this looks like. Kind of for you, any specific go-to things that you feel like in the clinic you've been able to have a lot of success with?
Well, I'll also say too, like plantar fascia and Achilles, especially when you get towards later stage, will start to look very similar in like what you're actually going to be doing with the patient. So like late stage, usually I'm talking about hopping and like plyometric stuff at that point. So you're trying to reintroduce like some quick stretch and reactive propulsion from the Achilles or the plantar surface of the foot, because even if they are not trying to get back into running, there are often times in everyday life that people are having to react to their environment, and sometimes a quick adjustment from the Achilles and plantar foot is necessary. I would say the key difference is more between the two is more in the early and mid stage. Early on, obviously, I'm going to focus more like great toe and plantar surface of the foot, and then I usually will incorporate a little bit more balance and like foot intrinsic in weight bearing for the plantar surface of the foot, in addition to the loading that I would normally get through plantar flexion and posterior tib and those muscles.
Yeah, I like that as well too.
I think
Go ahead, Drew.
I was going to add in that as you're moving to like the mid phase and working on a lot, or that mid phase, mid portion of the movement control, one thing that I often try to do is work people out of orthotics, especially if they're have been in them, or that help you're using that short term to help decrease those symptoms. I do like to work on that phasing out so that they're not relying on it, because I have people come in and say, "Oh, I've been told I'm supposed to wear shoes all the time. I'm never supposed to walk barefoot," and that's a lot of fear avoidance and things like that. So if you can start decreasing that, decreasing fear, that's a key part of mine as well. Mid portion
And they're
of
wearing
the
the shower
treatment phase.
shoes, can't get out of them. Yeah, no, I get you.
Yeah.
Lucas, what you got to add, man? I know you got a lot of thoughts on this setup as well too. Intervention wise, you got some early go to things, whether it's early, mid stage, or late stage.
Um, so it's everything that both boys here talked about. When it comes to tendinopathy, what I find it the most useful is a very thorough plan with the patient, going from the standard that is supported by the literature on isometric, isotonic, eccentric, plyometric sequence. When do you go into one stage to the next stage? Um, clo- Closed kinetic chain, loaded exercise is more prevalent, more efficient than open kinetic chain. So this is so stepping back a little bit of what was talked so far here today is like for those who are watching who will be like, okay, but when do I use what, when, where, who? That's where before you start the evaluation portion of these patients are really like you need to put together a really solid plan of care. Where you're gonna do, how much you're gonna do, how often you're gonna do. The literature is plenty in relationship to what exercise to do, when to do. It's hard to find anything that goes along the lines of a program through which in through 3 to 4 months, which is usually what it takes for tendinopathy to truly resolve, to get into that and avoid any explosive exercise in the beginning, finishing like what Mark said with more like explosion, plyometric, landing, exercise with eccentric component, concentric component that will get this patient back to if it's a young and active individual versus if it's a senior that just does step up and down from the home or in and out of car, in and out of chair.
Yeah, I think that's really good stuff. One of the things I was thinking through here and how important it is, as we all know, with this population, what they're doing at home is incredibly valuable and more so than what we're doing in the clinic. And
So
then
the
at the same time,
isometric is a daily exercise, right?
yeah. So, and again, with in terms of how you're communicating with the patient on pain levels, I mean, we know no pain's not going to get it done. Beating yourself up too much is also going to set you back a little bit.
Right.
Of the three, did anybody have a good tip on how to communicate with your patients around just that educational piece of where they want to be at in between sessions when they're working on this at home?
I mean, I talk about, I use the Goldilocks zone. So, like, if you do too much, it's going to set you back. If you don't do enough, it's not effective. You can also
Exactly.
use like dosing medication. There's a therapeutic dosage to medication, there's a therapeutic dosage to exercise. And so they have to stay within certain parameters that I'm going to be very specific with them. Sometimes I'll use 2 points on the NPRS, other times I'll use less than five. It kind of depends on the patient that's in front of me, but giving them specific parameters on like this is acceptable, this is not acceptable. If you have what's considered not acceptable, I need to know so that I can tweak the variables and get you back in that Goldilocks zone.
Yeah, I think that's great. I love utilizing the language as well around tissue remodeling to some degree, and not that you have to nerd out too much on that for some patients, but I've really seen patients take to the effect that, hey, we're trying to build your tissue's ability to take load here, and it will, and it'll do that in response to your load as well too. And so I think people kind of get a good sense of ownership about that, which is fun to work with as well. So um, instead of hitting outside elbow, we're gonna call it, since we're up to about 14 minutes here, and we want to keep these a little bit shorter so everybody can get through them quickly. So we're gonna cut it here for the day, and we'll see you back here next week. Appreciate it, guys.
Thank you.